stressful thing on its own, but having it that is not going as smooth as what we think or as straightforward as we think, that is even harder. So, my name is Hesham. I'm one of the emergency medicine consultants in Hampshire hospitals in the United Kingdom, and it's my pleasure and absolute honor to be with you today here. So, I'm really glad that my previous colleagues didn't cover anything that is shockable, and they focus on the non-shockable things, which is going to give me the chance to be the first to talk about shockable rhythms. So in this talk, we're going to cover a real case about a child who presented with a cardiac arrest that was quite challenging to manage. So here is our story. This was a 14-year-old boy who collapsed while cycling and found to be in a ventricular tachycardia, received 2 shocks, and now we've got ROSC. We are, by the way, in a pre-hospital setting, so this was not in an emergency department, that was pre-hospital. So the rhythm that this child had while the resuscitation was ongoing was this. I'm going to give you 10 seconds to have a look at this, and I'm going to ask, if you think that you know what's going on, can I see hands up, please? Thank you. I'm really happy with this, otherwise I would have just jumped to the conclusion. So, let's carry on with the story. So, post-ROSC, the blood pressure was low. We are still pre-hospital. So the pre-hospital critical care team gave a small dose of IV adrenaline just to support the blood pressure for a bit. And surprisingly, immediately after, the child went back into VT cardiac arrest. They've resuscitated the child, they've got ROSC, they've given more adrenaline, and it happened again. And at this point of time, everyone stopped and started thinking, what is going on here? Something is not quite right. We are following the normal cardiac arrest algorithm, and we're getting a bit of a weird response. So, let's have a quick look at the rhythm strip that we've just seen, because the answer is there. This was the rhythm strip of the child during resuscitation, and if you focus on this one, especially at this part, you will get the answer. If you focus at this part of the rhythm strip, you will notice that the complexes are following a very specific pattern. This is the axis of this complex, this is the axis of the one after. Up, down, up, and down. This is very specific, and it's just characteristic, and it's going on throughout the whole rhythm strip. When you see this, think about bidirectional VT. So this is what we're going to talk about today. So bidirectional VT is a rare ventricular dysrhythmia that is characterized by a beat-beat alternation of the QRS axis. So the axis changes with every beat. And let's have a quick look at some examples. If you look at this example from Live at the Fastlane website, it is very clear in the rhythm strip at the bottom end that the axis is changing 180 degrees with every beat. This is characteristic for bidirectional VT. Here's another example, again from Live at the Fastlane. And it might look a little bit chaotic, but if you look at the top rhythm strip at lead 1, again, the complexes are quite clear there, and you can clearly see that the direction of the complex changes every beat to the opposite end. So, Christmas tree sign is kind of, in my personal opinion, a fancy, fun sign that they came up with. Basically, they say that if you see an ECG like this, then you can turn it anti-clockwise 90 degrees and it will look like a Christmas tree. To be honest, if you're looking at that ECG and you're trying to think about Christmas trees, you're just missing the point. This is a scary looking ECG that you should pay more attention to and give it more respect. But anyway, so one of the common questions I get when I talk about bidirectional VT is always, how do I differentiate this from a ventricular bigeminy? Because they can look similar. Look at this is ventricular bigeminy. And this is bidirectional VT. And you can clearly see that they can confuse people sometimes. But the answer is easy. If you look at the ventricular bigeminy, the top rhythm strip, you get a normal beat followed by an ectopic beat. So the normal beat will have a P wave. That doesn't happen with bidirectional VT. And the ectopic beat, they usually come earlier than expected, followed by a pause. Again, that doesn't happen with bidirectional VT. It is a regular rhythm. So this is how to differentiate the two from each other. So if we go back to the rhythm strip of that child, you will notice that there are no P waves anywhere. It is fairly regular, so that is a bidirectional VT. Now the question is, what can cause this? There are a few causes that can present with a rhythm like this. If we're dealing with an adult, please think digoxin toxicity. Again, that would be a ventricular tachycardia that will not respond to any sort of resuscitation that you would do other than the digibind. If you're dealing with a child, think about CPVT, and we'll talk about this in a minute. There are some other causes that's been reported to cause some bidirectional VT incidents, but they're not that common to happen with them. So, we're dealing with a child, so let's just focus with the CPVT. Let's talk about catecholaminergic polymorphic ventricular tachycardia. So this is also known as exercise-induced polymorphic ventricular tachycardia. This is a VT that happens with exercise in children. Can you imagine the life of that child who's not supposed to exert themselves? That's a genetic condition with a prevalence of 1 in 10,000. And it is characterized by recurrent syncopal incidents that happens during exercise or with emotional stress. So anything that will increase the adrenaline in the body of this child can cause ventricular tachycardia, which can result into syncope. This happens without any structural heart problems. It will be normal, cardiac MR will be normal, and it happens with a normal baseline ECG as well. So the underlying cause of these symptoms is usually ventricular tachycardia, either bidirectional or polymorphic. So the arrhythmia is usually self-terminating. Or let's put it that way, if the arrhythmia is self-terminating, the outcome will be a syncopal event. If it is not, then the outcome is going to be a cardiac arrest. So the mean age of presentation with the syncopal episodes is usually between 7 and 12 years old. But there have been case reports about this happening in the 4th decades of life. Moving on, if untreated, that is a highly lethal condition. And 30% of the affected individuals will have at least one cardiac arrest in their life, and 80% of them will get syncopal events, one or more, during their lifetime. And the sudden death can actually be sometimes the first manifestation of that condition. Okay, how do we diagnose this then? Well, the diagnosis happens via something called exercise test. So that is coming from the European Society of Cardiology Guidelines 2015, and here's the exercise test of these patients. Top to bottom, normal ECG, normal rhythm at rest. Then they start exerting the kids, and after 30 seconds, they will start getting some ectopics, maybe ventricular bigeminy, like here. Another 30 seconds, and we are having an unhappy heart, and in a minute and a half, we're having a bidirectional VT. Then they stop the exercise, and they let them recover, and within about 4 minutes, the heart rate will start going back to normal. So this is the exercise test that is used to diagnose these conditions. Treatment is interesting. So exercise restriction in a child, so quite challenging, and they all get beta blockers on board. That's the mainstay of treatment in these cases. Some cases will require flecainide to be added on to the treatment, and if cardiac arrest happens, then they need to have an ICD implanted. And lastly, invasive EPS is not recommended in these cases. To be honest, I think we're all emergency physicians here, so a slide like this one doesn't really attract our attention because this is not our job. This is a cardiologist's job. Our job happens here, and this is, in my opinion, the most interesting part of this talk. when they get the cardiac arrest, this is when we see them, this is when we deal with them, and this is when we manage them. And this is quite interesting because talking about shock algorithm, every single life support algorithm that I know, shock algorithm is treated by CPR, shock, adrenaline, and maybe amiodarone. We're now talking about a cardiac arrest that happens secondary to adrenaline. Are you going to give adrenaline to this case or not? That is the question. And if you search in the literature, you won't find much. You'll find few things, like this one. So that's an interesting paper talking about ventricular-nervic polymorphic ventricular tachycardia. When cardiac arrest happens, adrenaline is contraindicated. So it's not a good idea to give adrenaline here. This is the conclusion of this study, and they said that you should have a high suspicion, high index of suspicion when it comes to a child in a shockable rhythm. We know that the commonest presentation of kids, they present in a non-shockable side of the algorithm. When they are having a shockable rhythm, think about CPVT as a possibility. And if you're trying hard to resuscitate a child and things are not getting better, then consider CPVT and then change your approach. They're talking here about giving IV opiates, fentanyl specifically. This is what they talked about in the paper. General anesthesia, trying to blunt the sympathetic response. And to consider giving flicker-mide, and more importantly, to not give adrenaline. It'll just make things worse. So, this is coming from Dr. Smith's blog. Stephen Smith is a famous name in the emergency cardiology world and emergency medicine world. And when he talked about this, actually the recommendation was to give beta blockers IV. So specifically talking about esmolol IV. In my hospital, we have an algorithm that we use for resistant or refractory VF cardiac arrest, and it includes giving magnesium, and it includes giving esmolol there. What you're trying to do is you're trying to block the beta receptors so the adrenaline works on the alpha receptors. But in this particular case, you're just trying to stop the effect of the adrenaline on the heart. So you're going to give the beta blockers, and you're not going to give adrenaline. So here's one of the papers talking about this, and by the way, Stephen Smith is one of the authors here, about using esmolol after failure of standard CPR in patients with refractory ventricular fibrillation. Here is another systematic review and meta-analysis talking about the value of beta blockers in treating cardiac arrest with ventricular fibrillation. And again, both papers talked about the value of giving beta blockers IV, specifically esmolol, in improving the survival of refractory VF patients. So, let's go back to Stephen Smith's blog. So we talked about the adrenaline, and now we know that we shouldn't give adrenaline to those patients. How about DC shock? The problem with DC shock is it actually results in intrinsic release of adrenaline. So his recommendations were, give beta blockers as a pre-treatment if you're planning to shock these patients, and you should shock them because they're in a shock of a rhythm. But try to give beta blockers IV. So IV is more pre-treatment before you give the shock, and that is to stop the shock-induced release of internal adrenaline in these patients. So, we're done with the theory part. Let's go back to our patient and find out what happened. So this was a child who was 14-year-old, collapsed while cycling, found to be in VT. You'll see 2 shocks and now in ROSC. The ECG showed in bidirectional VT. He was getting in and out of this, and he's had recurrent cardiac arrest following small doses of IV adrenaline that were given actually to support the blood pressure because his blood pressure was low. So what happened later was that the police phoned the mother of this child while resuscitation was ongoing to let her know that her child is having a cardiac arrest. And she told the police officer that, by the way, my child's got something called CPVT. So the police officer told the paramedics, who told the clinician looking after the patient. So they've stopped giving all the adrenaline that they were planning to give. They carried on with IV fluids. They didn't have pre-hospital IV esmolol, so they didn't give it, but thankfully, the child didn't go into a further cardiac arrest. He was transferred to Southampton University Hospital as a tertiary center with pediatric ICU, and luckily, he actually did really well. He had an ICD implanted, and he survived with a full neurological recovery to be discharged home a few weeks later. So that was a happy ending for this one. So a learning point, so I don't take any more of your time. When it comes to bidirectional VT, it's caused by, if you're thinking about an adult, think about the toxin toxicity. And if we're thinking about a child, think about CPVT. Regarding the CPVT, this can cause cardiac arrest that gets worse with adrenaline and DC shock, and it will be a shockable rhythm. So please be careful about that, and please go against your nature when you take cardiac arrest. Do not give adrenaline and give instead beta blocks. Thank you very much. Happy to